Thank you so much for having me. It's a pleasure to be here. And this is the first lecture of the day. The title of the lecture is discussing the prevention of Alzheimer's disease, basically. But I thought that a good way of starting this lecture would be to give you an overview of what is Alzheimer's disease, because as I go out in the community and give these talks and as I meet my patients, I see a lot of confusion around what exactly is Alzheimer's disease and how does Alzheimer's disease actually differentiates itself from dementia. And I'm going to touch on that topic on the first part of my lecture, and then I'm going to delve into the evidence of Alzheimer's disease prevention. And I think that with the first part of my lecture, you will have a clear understanding of what we mean by Alzheimer's disease prevention. And then the subsequent talks today are going to delve a little deeper into exactly what can we do to prevent Alzheimer's disease. Looks like this has stopped working. So the first question really is, what is Alzheimer's disease? And I think for us to really understand what we mean, what we neurologists, specialists mean by Alzheimer's disease, you got to understand a little bit of how doctors think of diseases in general, okay? So bear with me here. This will make sense to you. This is a little bit dense, but please bear with me. So every doctor, when a doctor is thinking of a disease that is affecting any part of the body, the doctor is thinking of different signs and symptoms that are being produced by that disease, right? And we think of signs as an objective manifestation of a disease, whereas a symptom is a subjective manifestation of a disease to the doctor, subjective and objective to the doctor. To you, the patient, to me, the patient, it's all very objective, right? But to the doctor, some things are objective, some things are subjective, and I'll explain what I mean by this. And when a doctor sees a group of signs and symptoms that coalesce together, that come together, indicating that there is a specific disease of the body, we doctors call that a clinical syndrome, okay? So I'm going to run you through an example. It's not related to the brain, but this example, I think, helps cement this idea in our minds. So think of what happens when somebody has a lung infection here. This is a cartoon of a lung. This is the airway. You're breathing air in. It's coming into your right lung, your left lung. And this is sort of like a root system. I don't know if you've seen the pictures of the lungs inside, but it's like a root system, a big trunk of air, and it starts to subdivide into many, many roots, basically, until you reach the very end of a root system, and you reach this area that is called the alveoli. And you're taking air in here. This is cut so you can see inside. And the air is basically being forced out of your alveoli into your bloodstream, right? And then from your blood, from your lungs, it's going into your heart, that blood rich in oxygen, and then your heart is pumping it all over your body. And that's how it has, basically how every cell in our body gets oxygen. But look at what happens when you have this disease process that we're calling a lung infection. This air space, this alveolar space, gets filled with basically junk. Bunch of dead cells, mucus, pus, and all of this that happens when you get a lung infection. So this is the disease, okay? This is what is happening physically to your body when you have a lung infection to your lungs. What are the signs and symptoms of these process? So I told you symptoms are subjective, right? So you get things like body aches, low energy, shortness of breath, chills. If you think about these things, to the doctor, these are subjective manifestations of disease. Why? Because I cannot measure them, right? I cannot measure your body aches. I cannot measure your low energy. I just have to trust your report of things and make note of them, right? But compare those symptoms with these signs of a lung infection. These are things that I can measure as a doctor. I can measure your temperature. I can listen to you cough. I can put my stethoscope in your back and listen to your wheezing that tells me that there's this process is happening in your lungs, right? And I told you that when I see a constellation, a group of signs and symptoms that is pointing me to a specific disease of the body, in this case a lung infection, I call that a clinical syndrome and I give it a name. This is called pneumonia, okay? So when I turn to my colleague and I say I'm seeing a patient with pneumonia, my colleague immediately knows that I'm referring to all of this, okay? So in other words, we go from a disease process up here, the disease, a physical change in a part of your body that is causing signs and symptoms that we're grouping into a clinical syndrome. Everything clear? So this is how we doctors think of all diseases of the body, including diseases that affect the brain, the liver, the spleen, whatever it may be. We're always thinking using the same model of thinking of clinical syndromes, signs and symptoms that are honing me into a disease of the body so I can make a diagnosis and then think of the treatments. So in this case, I would be thinking, okay, my patient has a pneumonia, because I can see all these things. Now, my next question is, what is causing the pneumonia? Is it a viral infection? Is it a bacterial infection? And that will guide my treatment. All right. So this is important to understand because we apply the same thinking when we have diseases that affect this organ, the brain. Okay? The major difference is that unlike the lungs, different parts of the brain, different regions of the brain do different things. So therefore, if you have a disease that affects the brain, any disease, the signs and symptoms that are produced by that disease are going to be different depending on what region of the brain is affected by the disease. The same is not true of many other organs in the body. Like if I have a lung infection, a pneumonia that is in my upper lobe or my lower lobe or anywhere in my lungs, I'm going to pretty much have the same signs and symptoms, right? But in the brain, it's very different. And this is very relevant to Alzheimer's disease. I'll show you in a moment. Here you have a brain that is looking this way. Okay, you're looking at a side view of the left hemisphere of the brain. And just to highlight the degree of specialization, of differentiation of different brain regions, here are the frontal lobes. And among many things, I'm going to give you a very crude neuroanatomy way of thinking of the brain. The front of the brain is very important for control of behavior, control of movements, and other forms of control. But if I move just a little bit backwards, I get to this strip of brain here that I'm highlighting with my pointer. It's called the motor strip. And it's solely dedicated to initiating movements in the opposite side of the body. So this brain region has only one function, initiating movements in the opposite side of the body. But if I move just a little bit backwards to a little strip of tissue here, we call this the sensory strip because here live the neurons that perceive and pick up all sensory information from the opposite side of the body. So if I were to have a stroke, for example, that affects one of these squiggly arteries that you can see overlying the brain, can you all see those? So if I have a stroke where a blood vessel either breaks or I develop a clot in one of those blood vessels, and my stroke is only affecting this region of the brain, what do you think will happen? Movement will be affected in the opposite side of the body. That's the picture of stroke that we're most familiar with when we think of stroke. Weakness, right? Droopy face, right? Arm not moving. But let me show you something here. The back of the brain is solely dedicated to visual interpretation. All of you, all of us. We don't see with our eyes, we see with the back of our brains. The eyes are receptacles, they're taking information in, but the actual processing, the recognition of things starts in the back of the brain. So let me ask you, if I have a patient that has a stroke in the back of the brain, what are the signs and symptoms? Visual. Will that person, as a result of that stroke, have weakness? No. Because the stroke has only affected the back of the brain. It hasn't affected the motor regions of the brain. We see this, okay? We see this level of specialization. I have taken care of patients that have become suddenly blind as a result of a stroke in the back of the brain. But they're moving around, they're talking, they're telling me about their problems because these regions are spared in that stroke. Okay? This is a very important a key message for this lecture, that different regions of the brain do different things. Here we have the temporal lobe of the brain, extremely important for memory function. This is a region of the brain that is very much involved in Alzheimer's disease. And therefore, persons that have Alzheimer's disease typically will have a lot of memory problems, right? So with that in mind, let's zoom into this brain because I want you to get a feel that microscopically, if you magnify and get very deep in the brain, you find neurons, basically. This is a picture of a neuron with a darker nucleus in the middle. Then you have these smaller, darker cells, the glial cells. Then you have this is a blood vessel cut across, and all this light pinkish tissue, this has been colored so we can see the structures, is the glue that holds everything together, the parenchymal tissue. So knowing that this is what the brain looks like microscopically, and of course, I'm showing you very, very deep microscopic features of the brain, but these structures are very nicely organized and interconnected so that we can have all these division of functions in the brain, right? But microscopically, this is basically the most basic structures of the brain, and therefore, you can have different diseases of the brain that affect different parts of the brain. I already told you about cerebrovascular diseases. Those are the strokes, all right? They are affecting the blood vessels of the brain. There's demyelinating diseases like multiple sclerosis is an example of a demyelinating disease. It's a disease that affects a protective layer of neurons. It's affecting primarily neurons, not so much the blood vessels. You have infectious diseases like meningitis and encephalitis, right? Those are diseases that do not respect any boundaries. They're basically attacking the brain just like a lung is attacked by a bacterial, a bug. And finally, we have the degenerative diseases of the brain. This is where Alzheimer's falls. Alzheimer's disease is the most common degenerative disease of the brain. It's called a degenerative disease because, as I'll show you in a moment, this disease is slowly causing the degeneration of neurons more than anything in the brain, of neurons, the brain cells, okay? So let me show you what this disease, Alzheimer's disease, does actually physically. Remember, I was showing you earlier a picture of a lung infection, how a physical change in the lung leads to signs and symptoms of that physical change. Same thing in the brain. You have a disease that is a very physical change in the brain, as you can see here, that is leading to specific signs and symptoms of that change, of that disease. So here we have two brains. These two brains are about the same age. One is healthy, one has Alzheimer's, we'll say for purpose of this talk. What you see is that this brain seems to have lost a lot of volume, right? This brain is looking this way. That brain is looking that way. So they're looking opposite to each other. And if you look carefully, you see that the back of this brain looks a little bit similar to the back of this brain, meaning there hasn't been a lot of volume loss, but it's mostly the front of the brain that has lost volume, right? We'll say for educational purposes, we'll say that this is Alzheimer's disease because this is what Alzheimer's disease does to the brain. It attacks neurons inside of the brain and causes them to degenerate, to basically die very slowly through the years. And as a result of that process of decay, of degeneration, slowly the brain will lose volume in certain regions. But I want you to appreciate that this brain volume loss is regional, or we say focal. It's not affecting the entire brain. So if we go back to what I said earlier, therefore, if you have a disease that is affecting only some regions of the brain, then you're going to have unique signs and symptoms to that region, right? So let's take a look at exactly what is happening physically in this brain that has Alzheimer's disease. So there's basically, we think, based on our current understanding of the disease, two main drivers of the disease, let's say. Two main changes that are causing degeneration of neurons. One is the progressive accumulation of this amyloid protein. We are normally making amyloid in our brains. It's part of our normal brain structure. But for some reason, in patients that have Alzheimer's disease, and we don't know exactly why this happens, this naturally occurring amyloid protein starts to deform, okay? And you're seeing a cartoon here where your brain is making these amyloid fragments, and they become deformed to the extent that they start to clump into each other. They start to coalesce. They're sticky. They start to glue into each other, let's say. And they form the amyloid plaques, or the plaques of Alzheimer's. Has anyone read about the plaques or heard about the plaques? Yes. So you're seeing them here. Look, we've stained them in dark so you can see them clearly. You have the nucleus here in the middle. I showed you earlier what a healthy nucleus looks like. It's not surrounded by anything. Now you can see that it's being surrounded by this lattice of the amyloid plaque that is basically surrounding the neuron, and it's causing problems. I mean, it's not difficult to imagine that a neuron, if it's being surrounded by these plaques, cannot do its job properly, right? Now, keep in mind that we have billions of neurons in our brain. So if you have one of these, not a big deal. The issue is when your brain starts to accumulate a lot of them to the extent that your brain can no longer do its job. It's sort of like boulders, right? If you think of boulders on a highway, you put one, not a big problem. The cars can get through. But if over many years you start dropping more and more of these, eventually standstill, nobody moves, right? I like to think of it similarly. So those are the neuritic plaques, or the Alzheimer's plaques. And the other thing that happens is an accumulation of another different type of protein called tau, which has been stained also dark here so you can see it. And it's invading inside of the neuron. Here is a neuron that has a little bit of the invasion, not too much. Here you can see a neuron that has been completely taken over by the tau accumulation. Here you have a neuron that is almost about to be taken over completely. So this protein, which constitutes the tangles of Alzheimer's disease, is also obviously affecting neurons. So we have the plaques and tangles. Are you with me? Awesome. So, in summary then, when a pathologist, who is the doctor that actually looks at the brain inside and looks at the brain with slides, right? Takes samples of the brain, looks at these samples under the microscope, stains the samples different ways. When that pathologist sees that there is progressive accumulation of amyloid and tau that is leading to this loss of neurons, that pathologist will say, this brain has Alzheimer's disease, okay? It's a physical disease. It has been going on for many, many years, and as I'll show you in a moment. But the take-home message here is that Alzheimer's disease, the way we specialists use it, is to refer to an actual disease process of the brain, okay? A physical change. All right, so that's what we have regarding the physical changes of Alzheimer's disease, but it's important to make a little side comment that just as I just showed you, right, the actual pictures of Alzheimer's disease microscopically, there's many other diseases of the brain that have their own microscopic signatures. They have their own microscopic characteristics. Therefore, there are unique diseases in themselves. And they're divided by not only by their names, these are different names of diseases, but each one of these names has its own microscopic signature of characteristics. And also, very important, these diseases tend to affect different brain regions. Therefore, someone that has these diseases are going to look very different to a clinician or to a family member. For example, as you all know, Parkinson's disease, this is an example of a different degenerative disease of the brain. And this disease tends to not affect so much the memory centers of the brain or visual centers of the brain early on, but mostly typically the motor centers of the brain. Therefore, patients with Parkinson's disease have a lot of tremors or rigidity, falls, etc. Whereas in the early stages of the disease, they're still okay mentally. They can talk about things, they don't have problems with memory, and that's the reason why. Because each one of these diseases, especially in the early stages of the diseases, they affect different regions differently. So I've talked to you about Alzheimer's disease, going back to the scheme, but we've only talked about the disease. We haven't talked about the syndromes, right? I haven't talked to you about what are the manifestations of this physical disease. And that's not the purpose of today's talk, but I do want to just tell you a little bit that we have learned that Alzheimer's disease, this physical disease that I showed you, doesn't always present itself the same in every patient. We have longitudinal studies here in UCSF and across the country where we follow people that are healthy. They come to see us starting in their 50s or 60s, and they come to our center maybe once a year, once every 2 years, when we do a bunch of tests on them. We don't experiment on our subjects, meaning we're not putting things in their body. We're just collecting information from them, including tests of memory, MRIs of the brain, and any other tests that they're willing to do with us. So if they start healthy, then naturally, because we're all at risk of Alzheimer's disease, some of them will develop Alzheimer's disease as we follow them, right? So we're able to see the emergence of the disease in that person, the signs and symptoms of the disease. Doing those kinds of studies, we've learned that Alzheimer's disease does not always present itself in the way that we're used to thinking of Alzheimer's disease, where when I say Alzheimer's disease, what do you think of? Memory. Memory as a symptom, right? As the primary symptom or sign. Well, yes, that's what we call typical Alzheimer's disease. It's a type of Alzheimer's disease that manifests mostly with very, very severe problems, especially with short-term memory, right? In the earliest stages, and then slowly other things start to emerge. But that's the primary problem. Well, there's other variants of Alzheimer's disease too that we've learned. By far, typical Alzheimer's disease is the most common form of manifestation of Alzheimer's disease, but we have a posterior variant. So I told you the back of the brain does what? Vision. So we have a variant of Alzheimer's disease that we've learned about not too long ago, that affects primarily the processing of visual information. This is very different and has nothing to do with having blurry vision. That's more of an eye problem. This is someone that has no blurry vision. This is someone that sees their eye doctor. They're perfectly fine. Their eyes are fine, but they feel that they're not seeing well. They're bumping into things. They cannot drive. They're getting into accidents. They don't recognize faces of people. These people in the early stages of the disease, of Alzheimer's disease, their memory is fine most of the times because it's primarily the back of the brain that isn't working. Now you understand why, right? Because I showed you the brain does different things. We have another variant, the Logopenic Variant. This is a variant that almost exclusively in the early stages of the disease will affect language function. We've learned this through this type of research study, and we have research studies here in UCSF that are looking into this variant. And finally, we have another variant that is the Frontal Variant that affects the front of the brain mostly. And those people have a lot of problems with control of behavior. We call that the Frontal Variant of Alzheimer's disease. These are patients that suddenly, they were very socially correct and appropriate, and they're becoming very disinhibited. They're making, rude statements in front of people, not caring about hurting other people's feelings, things like that. They're just becoming obnoxious. We all have those family members, but we're talking about someone who has never been like that, and then starting in their 60s, 70s, or sometimes later, they have a dramatic change in their personality. Okay, but no clear signs of memory loss or things like that. It's just like they're not themselves anymore. So that's a little overview of those syndromes associated with Alzheimer's disease. So basically, this is a cartoon that gives you an overview of things. So you have a brain that is being affected by a disease, the amyloid and plaques and the tangles. And this disease of the brain can manifest itself in the patient in one of four main syndromes. One of four main presentations. The most common one is the memory syndrome that we're most familiar with, but just to let you know that there's others. And that's how these patients manifest early on. As years go by and the disease advances in the brain, then you have a person that started off having memory problems only, but then language starts to be affected and maybe behavior starts to be affected, okay? So that's a later stage. Everybody with me here? Am I making myself clear? Okay, perfect. This is very important that we understand because it answers the question, okay, what is Alzheimer's disease? I told you what the disease does to our brains, how it manifests in life, signs and symptoms briefly. That's not the focus of today. But then you ask, wait a minute, so what is dementia? Right? I haven't used the word dementia. So let me give you a very clear a picture of what we mean by dementia, because this is important for the purpose of today's talks. So let's say that this is a person that has the disease, okay? He's young here, doesn't have the disease, he ages, and as he progresses through the aging process, this person gets Alzheimer's disease. Let's see how that looks like. So here from his 30s to 60s, he has a healthy brain. If I were to look inside of this person's brain, take a piece of it, we can't do that. But if I were able to do that, look at it under a microscope, I would not find the Alzheimer's proteins that I showed you earlier. I will not find the plaques or the tangles. He's healthy. Okay. But then around his 60s, this is not true of everybody. We're just picking on one person. Somewhere around his 60s, his brain starts to change microscopically. And what I mean by that is that there is a slow accumulation of these proteins that I showed you, the plaques and tangles, right? But from his 60s to his 70s, this person is asymptomatic. This person goes to the doctor, he gets memory tests, he's doing fine. This person goes to the doctor with his family members. I interview the family members. Nobody's seen any change in their memory, visual processing, behavior. Everything seems to be fine. But if I were to take a sample of that person's brain, which I can't do in clinic, but we can find ways of doing this in research, I would find that that person's brain is already accumulating some of these plaques and tangles, okay? So we call that the asymptomatic stage of Alzheimer's disease. AD is Alzheimer's disease. So the disease is already happening in the brain. There's changes that we can measure, but symptomatically, the person doesn't have any signs and symptoms of the disease. This stage, we've learned based on research, it can be as long as 10 years, 10 to 15 years. This stage of asymptomatic Alzheimer's disease has opened the doors for people to study what are the things that we can do to stop the disease, right? What can we do? Can we do medications, lifestyle? What can we do to stop those physical changes from happening in the brain, right? So that we do not get to the next stage, which is something we call mild cognitive impairment. So this person has switched from not having any symptoms, although the disease is already happening, to starting to have mild symptoms of disease, right? And what do we mean by mild cognitive impairment? We mean that I see that patient in the clinic, patient is noticing some changes, family may be noticing them too, and I test that patient and I can verify that indeed, let's say their memory is not as good as it should be for his or her age and level of education, because we have norms to compare people with. But that person is still living fine. He's still enjoying life. He's still living independently. He may be working. So it's not a serious functional problem in their life. We call that, in a nutshell, we call that MCI, or mild cognitive impairment, okay? And then that sometimes leads to this stage that we call dementia, okay? So dementia means that this person has gone from having mild changes when starting in his 80s, it became more severe to the extent that now my tests clearly show that there's a problem, and that person functionally is very impaired, meaning that person needs help from family members or a caregiver. He or she no longer can drive, he or she no longer can work because the problems in cognition have become too severe. Is this clear? So we go from having a healthy brain to having some changes happening in our brain, but they're not causing any problems, to having mild problems, to having severe problems as a result of the disease. Okay? So this to highlight that you can have Alzheimer's disease changes of the brain without having dementia. Does that make sense now? If you look at this? Okay. The other take-home message here is that we can assign this diagnosis of mild cognitive impairment to someone, but we may not be sure that the cause of that person's mild cognitive impairment is Alzheimer's disease. So I see a patient, I do tests, they're not scoring well on memory testing, family's noticing it, but I'm not finding any clear evidence of Alzheimer's disease. I'm still going to say that person has MCI, mild cognitive impairment, but I'm telling myself, I don't know what is causing that MCI. I have to do investigations. It may be something else. It may be like a vitamin deficiency. It may be a thyroid abnormality. Does that make sense? Okay. So with this scheme, this long view of this disease, then now we start to think of, before I get there, this long view of the disease applies to all of these syndromes, okay? So you can have typical Alzheimer's disease that is at an MCI stage or at a dementia stage, or you can have the logopenic variant of Alzheimer's disease that is at an MCI stage or at an asymptomatic stage. Does that make sense? Okay, and we have ways now of putting our research subjects into these stages with not just a clinical interview, but what we call biomarkers. We can get measures of amyloid or tau protein in a person's brain through research using PET scans that tag those proteins, or taking a sample of the cerebrospinal fluid, a spinal tap, and measuring that fluid and see if it contains these proteins. So we were able to get a clear window into the brain, not as clear as actually getting a piece of brain, right, and looking at it under the microscope. We can't do that, but it gets us pretty close, okay? All right, so let's get back to this diagram here, because this opens up the conversation of prevention, okay? I gave you this long-winded background because when you hear our next speakers talk about these things that we can do to prevent Alzheimer's disease, now you will know what we think these things, these modalities, these practices are actually doing in our brain. We think that they may be actually changing that physical process. Does that make sense? Just like when you exercise, you grow muscles, or if you lift weights. Well, I exercise, I don't grow any muscles, but most people, if you raise weights, eventually your muscles are going to grow, right? Meaning behavior is leading to a physical change. Okay, same idea here. We have enough evidence to come out here and talk to you about these things because we think that there's certain behaviors that we can all engage in that may have a real physical change in our brains based on the evidence. That's the take-home message. So when we think of prevention, we think of primary prevention and secondary prevention. Primary prevention means that we're doing something right now that is going to prevent us from having the disease. In this case, it's something that we're going to do in this stage when we're still healthy that is going to prevent us from having those physical changes that I showed you in the brain, right? I'm not interested in this model. We are not so interested in the symptoms of the disease because, as you can see, that's kind of too late, right? If you're having signs and symptoms, you're already here or here. The disease has already started. Does that make sense? So when we think of primary prevention, we're thinking of doing things at this stage when somebody does not have symptoms and does not have any evidence of the disease in the brain, okay? When you're doing things to modify the disease or like halt it or slow it down, that's already secondary prevention, which is great. I'm not saying that we shouldn't do that. I'm just helping you divide conceptually things. And the rest of my talk is mostly going to concentrate on primary prevention. Studies that have been looking at primary prevention, trying to get healthy people and doing something so we prevent them from getting into these later stages. Okay, I have to say though that this is very much an emerging field, prevention in Alzheimer's disease. 30 years ago or 25 years ago, we were not even sure what was causing the disease. Like we were like, maybe amyloid is involved. Tau protein was not, too much a culprit. So this is relatively recent science. And it is very, very hard, as you can imagine, to do these type of prevention trials where we actually capture people from the community that feel healthy. Then we do all kinds of tests on them and find out that in fact they are healthy, meaning there's nothing going on in the brain that we can pick up, and then enroll them in a trial. That's very hard. So there's not a lot of actual clinical trials in primary prevention, but there are a few that look promising. And I'm just going to review some of the major ones here, okay? Before I do that, a big impetus, a big reason for us trying to prevent Alzheimer's disease is not only because it's a devastating disease, but also it has a significant, not only devastating for individuals, but as a society, it's significantly devastating, okay? So just some statistics here. It's the sixth leading cause of death in the United States. As I told you earlier, Alzheimer's disease is the most common cause of dementia worldwide. And now you understand what I mean by cause of dementia. It kills more than breast cancer and prostate cancer combined. These are statistics from the Alzheimer's Association, 2018 statistics. Early and accurate diagnosis could save up to $7.9 trillion in medical costs. Very expensive disease associated with costs of caregiving. It's a long disease, as I showed you earlier. You can have an asymptomatic phase that is even 10 years. And then once you hit the symptomatic phases, that can be another 15 years. So it's not, it's something that requires a lot of expenditures for a long period of time. And that's where the costs come in. And note that these costs are associated, these savings are linked to early and accurate diagnosis. They're referring here to already when somebody has asymptomatic phases. When they say early and accurate diagnosis, they're not talking about diagnosing the disease before it shows signs or symptoms. So if you can do that and do something about it, the savings will be even bigger, right? Because you're catching the disease before it even starts to produce signs and symptoms. Economists predict that preventing or delaying the onset of Alzheimer's disease by 5 years would cut Medicare spending for Alzheimer's by half. Significant financial incentives. Another big incentive for us to try to focus on prevention, perhaps even more than treatment, is that so far we have not come up with drugs that can actually cure this disease, that can actually stop it, or they can actually slow down the disease. What I mean by that is that the drugs that we have available do not actually go up to the brain and fight those proteins that I showed you, the plaques and the tangles. They don't do that. What they do is I see them more working on the healthy neurons, the healthy parts of your brain, and keeping them as healthy as possible. Okay? So that's also an important stimulus here. So earlier I told you, right, that this pre-symptomatic phase of Alzheimer's disease, meaning when somebody has a disease happening in the brain microscopically but no signs or symptoms, has opened up a lot of research into what are the things that we can do, or in other words, what are the modifiable factors that we can address to either slow it down, if it's already happening, or maybe even prevent it from happening. Okay, and this is the focus of today's sessions. First, let me start off with some non-modifiable factors of Alzheimer's disease. These are the main ones. We know that as we age, our risk of Alzheimer's disease goes up. That's something that we've learned through many different studies, and I think we're all familiar with it. I have patients that change their age in their IDs, but that doesn't work for this purpose. Females are at increased risk of Alzheimer's disease compared to males. Many studies suggest that. We don't know why. This is an area of research. I don't know why. We can fault the husbands, maybe. I don't know. Family history, very important. Genetics, basically. If you belong to a family that has multiple generations of people affected by Alzheimer's disease, then there may be a genetic piece to that family, a genetic risk factor, a strong genetic risk factor. Having said that, the vast majority of cases of Alzheimer's disease worldwide, they're not linked to any genetic factor. They're what we call sporadic. They can happen to anybody, any one of us. Head trauma, I put it here as a non-modifiable, but it's both non-modifiable and modifiable. What I mean by this is that we've learned through studies, retrospective studies, where we look back at histories of patients and research subjects, that people that have had serious head injuries, especially repeated head injuries, they are at increased risk of developing Alzheimer's disease later in life. Can't change those head traumas or that past head trauma, but we can certainly do things to prevent future head trauma, right? Not a good idea to pick up boxing when you're 60. I'm just gonna put it out there. And then most important for us and the purpose of these sessions are the modifiable things that we can do to lower our risk of developing cognitive impairment and Alzheimer's disease. These are the main medical conditions that have been studied that have been linked to an increased risk of Alzheimer's disease. And I think it's very important that we understand the concept of risk and not confuse it with causation, okay? We can think of several examples, right? If I let's say if somebody were to, like a teenager is a good example. A teenager is, getting ready to go out with his friends on Saturday, and this teenager starts having some drinks at home, then gets in the car and doesn't wear a seatbelt and starts speeding off the highway. Very clear that this teenager is increasing his risk of having a car accident, right? No doubt, risk is higher. But it's also very clear that none of these things are a guarantee that he's going to have an accident, right? So that's the concept of a risk factor. There's things that you may have or may be doing that are putting you at risk, at higher risk of an outcome, in this case, Alzheimer's disease, but they're no guarantee. In other words, you or someone you know may have all of these things going on with them. They're not seeing their doctor about them, and they may never develop Alzheimer's disease. But that doesn't mean that you shouldn't pay attention to them, right? So the message with these medical conditions is not that if you have them, your risk is immediately higher. No, it's if you have them and you're not taking care of them. So if I have high blood pressure and I am actively engaged in keeping my blood pressure under control, and I'm measuring it and I'm taking care of my diet and taking my medications and exercising, then we think that risk basically diminishes down to nothing if you're addressing it, okay? And then there's a bunch of lifestyle factors that our next speakers are going to delve to in more detail than I will, looking at exactly what can we do in each one of these areas to engage these risk factors so that we can diminish our risk of Alzheimer's disease. So let me show you some of the studies that brought this evidence to light. This is in 2014. This study came out from researchers here in UCSF actually, and it was very influential. And using statistical modeling, what they found is that if you reduce the prevalence, meaning if you reduce if you treat these conditions that you can see on the right, diabetes, midlife hypertension, meaning people that start to have high blood pressure in their late 30s, 40s, and you manage it. Midlife obesity, when you start to gain weight, again, in your mid-30s and your late 30s to 40s, but you manage it. And physical inactivity, depression, smoking, and low educational attainment. When you look at all of these things and we try to improve upon these things, then you can, if you reduce the impact of these things by 10 to 20% per decade, you can reduce the worldwide prevalence, the worldwide number of cases of Alzheimer's disease in 2050 by 8 to 15%. So that's 8.8 million to 16.2 million cases. So very powerful data. This study was very influential because it put numbers to the potential effects of reducing the impact of these modifiable risk factors. And they put it here graphically. In blue, you have the 10% reduction, and in red, you have the 20% reduction. And if you look at worldwide, in other words, if you reduce over the years by 20% the impact of these factors, then you are roughly reducing the prevalence of Alzheimer's disease by 15%, if you're more graphically inclined. So this is a very revealing study, and it's only 2014. So this is gathering a lot of momentum, okay? The impact of cognitive training and mental stimulation on cognitive and everyday functioning of healthy older adults, a systematic review and meta-analysis. This is an important concept. A meta-analysis is when researchers gather all the studies that have been put out in the medical literature. They combine all of those numbers and they do another analysis of all of the studies, okay? So what they found here was that compared to active controls, so the controls are people that are not being engaged cognitively, the cognitive training group improved performance of measures of executive function, that's front of the brain, processing speed, front of the brain, and also the composite, the overall measures of cognitive function. Then they say, compared to no intervention, cognitive training improved performance of measures of memory, and subjective cognitive function. Patients were both reporting that they were feeling better after engaging in this cognitive training, but also there were some measures of cognitive training. This is also 2014, and very recent, and they're saying, the impact of cognitive training on everyday functioning is largely under-investigated. So there is not, even though they came up with this study that compiles all of the studies, they still think that there's much more that we can do. Okay, so again, highlighting that evidence is emerging here. Now, this is another systematic review and meta-analysis looking at physical activity. This is an area that has been more studied than cognitive stimulation. I'm not going to delve too much into details here, but the take-home message is that if you look at this graph, I took this from the paper, each one of these lines is one study, 2001, 2002, 2004, different studies, names of the authors. And here, the way to look at this that makes sense is that if you look at this line here in the middle, that's splitting studies that had a positive effect, which would be on your left, from tests that had a negative effect, which would be on your right. And you can see basically that almost all of the studies done individually by different authors, not related to each other, just individual studies, most of them point towards there being a positive effect of exercise on cognition. This is the association between high physical activity and cognitive decline. And our speakers later are going to tell you exactly what are the recommendations, how much exercise should we be doing, and what type of exercise, okay? And they did a similar chart looking at actually association between high physical activity and actual dementia, and now you know what that means. It means severe cognitive impairment, right? Same story. Most of the studies are more geared towards the left, indicating that there is a significant positive association between physical activity and protecting yourselves from dementia. In my opinion, physical activity is the most important thing that you can do. If you're going to touch on any of these lifestyle factors, physical activity closely followed by avoiding loneliness, avoiding the sensation of loneliness. Now, what I mean by that, we can be surrounded by 15 people all day, but we can still feel lonely, right? If those social connections are not enriching. So what I showed you earlier was a meta-analysis, right? Where they're looking at all these studies, putting all the numbers, but now people are doing actual clinical trials where instead of giving you a pill, they give you exercise routine, right? And comparing groups of people, the people that are active with the people that are not active, instead of comparing people that take the drug versus those that don't. And I like to think of exercise as a pill that takes 30 minutes to swallow. Yeah. And so think of it that way. So this is the fitness for the aging brain study. And I want to put the main findings here. So they looked at 170 subjects, volunteers, ages 50 or older, that had memory problems. So this is already, that makes you think that this is not a primary prevention study, right? Because if they're saying that they already have some memory problems, you wonder how many of these people actually already have Alzheimer's changes of the brain. They didn't test for that, but it makes you wonder. And they even included patients that have MCI or were suspected to have mild cognitive impairment, okay? So some underwent a 6-month home exercise program, supervised, very structured, and others just received educational sessions about the importance of exercise and usual medical care. And they found that the active group, those that were being pushed to do the exercise program, had significant signs of cognitive improvement at the end of 6 months. And most importantly, the effects seemed to be enduring because they checked back with the group at 18 months and they still had better cognitive performance. Okay? So this is an example of study. There's other studies like these that are actually, and we're also very interested in doing studies like these, hopefully in the near future, where we can bring people that are asymptomatic, expose them to an exercise program, and then seeing what happens. So they did a similar study doing not physical stimulation, but cognitive stimulation. So this is not just rounding up studies and looking at the data. This is actually prospectively, doing an intervention around cognitive stimulation. And this is a larger study. So starting in 1998, they recruited 2,832 participants between 65 and 95, and they put them in one of four groups. one group had memory training program, another one had reasoning training program, speed of processing training program, and then the fourth group, there was no training. That's the control. They're just coming in. They're not doing any active training, maybe educating them about things, but nothing active. And they reported results at 2 years, 5 years, and 10 years. And basically all participants who were in the training groups, they all noted less difficulty in all complex activities of daily living when they were asked at the 10th year of follow-up. Again, encouraging results. This is not a perfect study because, the 1998, this is way before we knew everything we know about Alzheimer's disease, but still a pretty good study. Similar studies looking at the influence, as I was telling you earlier, right? Loneliness, having a poor social network. This is from, I think, also recent. I don't remember the date exactly, but they followed 1,200 Swedish citizens aged 75 years or older who were cognitively healthy at the start of the study. They were not reporting any problems, and based on their crude assessments, they didn't see any problems on these patients. And after 3 years, they found that about 176 of them developed dementia, or let's say severe cognitive impairment. And by the way, they found that mostly were elder females. And I told you earlier that being female is a higher risk of Alzheimer's. They had low educational attainment. This is another big risk factor, which coincidentally was found here in this study. People that have less than high school education are at increased risk of Alzheimer's disease compared to those that do have high school and above. And also they found that people that were not very much stimulated cognitively also had increased risk. But they found that being single, living alone, and not having relatives or friends each increased the risk of developing dementia compared to those that didn't. So in other words, people that had more close relationships with their community, like coming to the JCC is a great way of staying knit with your community, right? And that in itself, that activity, that behavior is in itself protective. So the key for me is that you do these things, but you also find ways of finding enjoyment in them, and that should be protective. And being single and alone was the strongest determinant in this study of developing cognitive impairment later in life. And they broke it down graphically too. If you have extensive social support, then your risk is much higher than if you have poor social support. Your relative risk of developing cognitive impairment goes much higher. So that's all I have. I'll leave you with this quote. The secret of change is to focus all of your energy not on fighting the old, but on building the new. So I hope you carry this to the rest of the day. Not sure. And I think I have a few minutes for questions. We'll start on this section and then we'll move to this section. Yes, sir.
I understand there's a type of dementia caused by vascular abnormalities of the brain.
Yeah.
And can you differentiate that? And do the studies pertain to prevention of this particular variety?
Yes. So as I said earlier, there's many different causes of dementia. We've been talking about Alzheimer's disease, but in some patients, one can develop dementia as a result not so much of Alzheimer's disease changes of the brain, but as a result of vascular disease. So when somebody, for example, can have a lot of small strokes in the brain, and they affect different strategic areas of the brain, like the areas that are involved in memory function, then the person will have memory problems, right? And what can we do to prevent that form of dementia, that vascular dementia? Coincidentally, it's a lot of the things that I showed you here, meaning people, the same risk factors that put us at risk of having strokes or vascular injury are the same that put us at risk of Alzheimer's disease. There's a link there. That is also an area of research because there's a lot of overlap between things that are good for our heart health and our brain health from a vascular perspective that are also good for our brain health for the Alzheimer's disease perspective. So exercise, controlling your high cholesterol, hypertension, things like that. Yeah.
Two quick questions. I know we're talking about Alzheimer's and not ALS. Do you have any opinion as to whether the head hits that Dwight Clark suffered had anything to do with him getting ALS? My other question is, you mentioned a higher risk for people that are lonely and don't have a big social life. Is that a separate analysis from people just getting older who, the way it is, that's people around them, their partners pass away, and just being older makes you more isolated?
People have tried to separate those, and the study suggests that there are two separate things. One is aging, the biological process of aging, and that puts us at risk of these diseases. And the other one is not only aging, but also aging feeling isolated, feeling lonely. That adds to that risk. And keep in mind that the way we live now is not the way everybody else lives, and it's not the way that we used to live in, right? I mean, right now we have a very interconnected world where, I mean, I'm a good example of this. I was raised in Peru, now I'm here, and my parents are in Peru alone. But that wasn't always, or they're not alone, they're without me and my sister, but they have a good family structure. But that was not always the case. We had these family units that would stick together, right? And you had elder people that actually had a role within that family unit. The sort of the village perspective of things, if you want to put a name to it. And this is my personal view of things. I think that's being lost as we quote unquote develop, and it has a problem. In fact, people have shown studies show that even though we lose cognitive abilities as we age, we also gain in this thing called wisdom. Right? People have actually operationalized the idea of wisdom and how that tends to increase as we age. Even though our memory may drop, we have wisdom, which to me means you lose touch with the minutia of life, but you don't lose the big picture view of things. And you're able to, provide this amazing advice to an otherwise younger person that is completely lost in the minutia of things. And that was the role of the elder. But that's kind of not always there now. And the other question, ALS and head trauma, no clear, to my knowledge, no strong linkage there. There is strong linkage with head trauma and Alzheimer's, as I showed you. And also another type of disease of the brain called CTE, chronic traumatic encephalopathy, which has been in the media a lot because of the football players. That is in itself a unique disease. I mean, if I look at a brain with CTE, it has its own hallmark microscopic features that Alzheimer's doesn't have. Yeah.
I think that's all the time that we have. So thank you all for coming. And let's give a big hand.
Thank you.